Good day. This is Constance speaking. I'm here with Megan and Nolazi. We are going to present to you valvular lesions regurgitations. There are four types of valvular regurgitations, which results from the aortic valves themselves being dysfunctional. Aortic regurgitation, tricuspid regurgitation, pulmonary regurgitation, and mitral valve regurgitation. Talking about the heart valves, we know we have four chambers in the heart, two upper chambers and two lower chambers, which are the atria and the ventricles. We know that blood passes through a valve before leaving each chamber of the heart. The valve prevents backward flow of blood. Valves are actually leaflets that acts as a one-way inlet for blood coming into a ventricle and one-way outlets for blood leaving a ventricle. Normally, valves have three flaps, except the mitral valve, which has only two flaps. The aortic valve is the one that is located between the left ventricle and the aorta, and the tricuspid is located between the right atrium and the right ventricle. The pulmonary is the one located between the right ventricle and the pulmonary artery, and the mitral valve is located between the left atrium and the left ventricle, as seen on the structures that are on the picture. Now, let's look at how the valves work. As the heart muscle contracts and relaxes, the valves open and shut. This lets blood flow into the ventricles and atria at alternative times. Here is a step-by-step description. When the left ventricle relaxes, the aortic valve closes and the mitral valve opens. This lets blood flow from the left atrium into the left ventricle. The left atrium contracts. This lets even more blood to flow into the left ventricle. When the left ventricle contracts, the mitral valve closes and the aortic valve opens. This is so blood flows into the aorta and out to the rest of the body. While the left ventricle is relaxing, the right ventricle also relaxes. This causes the pulmonary valve to close and the tricuspid valve to open. This lets blood flow into the right ventricle that was returned into the right atrium from the body. When the left ventricle contracts, the right ventricle also contracts. This causes the pulmonary valve to open and the tricuspid valve to close. Blood flows out from the right ventricle to the lungs before it is returned to the left atrium as fresh oxygenated blood. What is regurgitation? Regurgitation is a leaky valve. This means that the valve doesn't fully close and the blood flows backwards through the valve. This results in the leakage of blood back into the atria from the ventricles in the case of the mitral and tricuspid valve, or it leaks back into the ventricles in the case of aortic and pulmonary valves. This can cause the chambers to be overworked because they have to repump extra blood that was retained. Over time, this can cause structural and functional changes in the heart chambers. These changes prevent the chambers from pumping blood normally. The definition of the aortic valve regurgitation. As we have explained before, it occurs when your heart's aortic valve doesn't close tightly. It is the flow of blood back into the left ventricle from the aorta during the diastole. Aortic valve regurgitations allow some of the blood that was pumped out of your left ventricle to leak back into it. And then we know that because it is located between the left ventricular outflow tract and the ascending aorta, it prevents the regurgitation of blood from the aorta to the left ventricle during the ventricular diastole to allow the appropriate flow of blood from the left ventricle into the aorta during systole. The three principal components of the aortic valve are the annulus, the cusp, and the commissures. The annulus is the collagenous structure which lies at the junction of the aortic valve and the ventricular septum. It is also referred to as the aortic ring and serves to provide structural support to the aortic valve complex. There are three aortic valve cups, the left, the right, and the posterior one. Each one of them is half moon or semilunar in appearance. The commissures, each cup is attached to the wall of the aorta by the outward edges of its semilunar border. The small spaces between each cup's attachment is called the aortic valve commissures. The etiology of aortic regurgitation. When we look at aortic regurgitation, we know that we have the acute one and the chronic one. From what you see on the screen now is what is basically the main causes, which are infective endocarditis, aortic dissection, and trauma. These first three, they normally cause the acute AR, and with the chronic AR, it is caused by inflammatory lesions that deform the leaflets of the aortic valve. Also, rheumatic heart disease, congenital abnormalities, trauma to the chest, systemic lupus erythematosus, and rheumatoid arthritis, and also ankylosing spondylitis. We also have connective tissue disorders that also cause this chronic AR, which are Marfan syndrome, the floppy aortic valve, the aortic valve prolapse, and the aortic annular fistula. The clinical manifestations of the aortic regurgitation, most often aortic valve regurgitation develops gradually and your heart will compensate for the problem. You will have no signs and symptoms for years and may even be unaware that you have the condition. However, as it worsens, the signs and symptoms may include fatigue and weakness, especially with increased activity level, shortness of breath with exercise or when you lie down, swollen ankles and feet, chest pain, discomfort or tightness, often increasing during exercise, lightheadedness or faintness, irregular pulse, heart murmur, or sensations of a rapid fluttering heartbeat. Now we look at the physiology, pathophysiology of the aortic regurgitation. Um, as the right atrium is pumping blood into the left ventricle, we see that there will be increased blood volume in the left ventricle during the diastole. And because there won't be enough time for the left ventricle to dilate, in response to that, the left ventricle and diastolic pressure will increase rapidly. And from that, we will see an increase in the pulmonary venous pressure, resulting in that as the pressure increases in the whole circuit, then the patient will develop dyspnea and pulmonary edema. And in severe cases, there is heart failure and also cardiogenic shock will result. And with decreased myocardial perfusion, it may lead to myocardial ischemia. It is not on the screen, but I will also like to share the pathophysiology of a chronic aortic regurgitation. As severe AR occur, it may occur in a normal effective forward stroke volume and a normal ejection fraction, together with an elevated left ventricular and diastolic volume, pressure and stress. According to Laplace's law, the wall tension is related to the product of the intraventricular pressure and the radius divided by the wall thickness. The left ventricle dilatation increases the left ventricle systolic tension required to develop any level of systolic pressure. Thus, it increases in the preload and the afterload. The left ventricle systolic function is maintained throughout the combination of the chamber dilatation and the hypertrophy, which leads to eccentric hypertrophy. In compensated aortic regurgitation, there is sufficient wall thickening so that the ratio of ventricular wall thickness to cavity radius remains normal. During the early phase of chronic AR, the left ventricular ejection fraction is normal or increased due to increased preload, and the patient may remain asymptomatic during that period. But as the aortic regurgitation progresses, the left ventricular enlargement surpasses preload reserve in the Frank-Starling curve, with the ejection fraction falling to normal and then subnormal levels. The left ventricle and systolic volume rises and is a sensitive indicator of progressive myocardial dysfunction. And we must take note that the severity of the aortic regurgitation is dependent on three things, which is the diastolic valve area, the diastolic pressure gradient between the aorta and the left ventricle, and the duration of the diastole. Eventually, the LV reaches maximum diameter and diastolic pressure begins to rise, resulting in dyspnea. Increasing left ventricle and diastolic pressure may also lower the coronary perfusion gradient, causing subendocardial myocardial ischemia, necrosis, and apoptosis. Complications of aortic valve regurgitations are heart failure, infections that affect the heart, such as endocarditis and heart rhythm abnormalities, as well as death. In treating the aortic regurgitations, the patient can be treated with for cardiac failure with diuretics, vasodilators, and angiotensin converting enzymes and inhibitors and digoxin. Restriction of strenuous physical activity can also help, and salt restriction. For infective endocarditis treatment, the patient will have to be on 4 to 6 weeks of treatment following a culture and a sensitivity test. A surgical treatment involves aortic valve replacement for patients with severe chronic aortic regurgitations who develop signs and symptoms of cardiac failure, and these patients require lifelong anticoagulation.
So I will be focusing on tricuspid regurgitation, following through. Tricuspid regurgitation is insufficiency of the tricuspid valve causing backflow from the right ventricle to the right atrium during systolic pressure. Causes of primary regurgitation, valvular abnormalities. So you will have congenital heart disease, valve abnormalities, other conditions. We have the
Epstein's anomaly,
infective endocarditis,
carcinoid syndrome,
implantable device wires,
endomyocardial biopsy,
blunt chest trauma, and
fever,
and radiation. On the other side, we have causes of secondary tricuspid regurgitation, leaflet tethering caused by reduced leaflet coaptation caused by annular dilation and
or papillary muscle.
Displacement mostly common as a result of left heart disease causing pulmonary hypertension. So the clinical manifestations, we have fatigue, weakness related to reduced cardiac output, right side failure, ascites, hepatosplenomegaly, pulmonary effusion, peripheral edema. At a later stage, you have cyanosis, jaundice, and arterial fibrillation. So in our patho, tricuspid valve regurgitation focuses on the structural incompetence of the valve. The incompetence can result from primary structural abnormalities of the leaflet and the cordia. It can be secondary to myocardial dysfunction and dilatation. Valve dysfunction in this condition has back between right heart chamber and right heart ventricles. Blood flows back into the upper right chamber.
Yes, as with the Epstein anomaly, the pathology and the pathophysiology involved there is that the septal and the posterior leaflets of the tricuspid valve are displaced into the right ventricular cavity so that a portion of the right ventricle is incorporated into the right atrium, where we see resultant functional hypoplasia of the right ventricle and tricuspid regurgitation. And interatrial communication is present, resulting in right to left atrial shunt and varying degrees of cyanosis.
And then with investigations and physical examinations, cardiac auscultation, we will investigate or examine murmurs, maneuvers, heart sounds, palpation. We'll have examinations if there is edema or hepatomegaly. With investigations on the other side, we have electrocardiogram, chest X-ray, or cardiac catheterization, exercise or the stress test, and cardiac MRI.
Yes, with these clinical manifestations, we can see that when we listen to, auscultation of the heart, we will find that the S2 is widely split, and then there is a characteristic triple or quadruple rhythm consisting of a split S1, split S2, S3, and S4 is present. A soft regurgitant systolic murmur of tricuspid regurgitation is usually audible.
Following through, we have surgical management. We have repair using an annuloplasty ring. So in the middle of our presentation here, you can see exactly how they insert and place the annuloplasty ring. It involves the use of tissue-based and synthetic ring to reinforce the annulus, which is the ring of tissue at the base of the valve leaflets. This procedure restores the annulus to right size and shape and allows the leaflet to open and close completely.
The second part of surgical management would be the leaflet purging, which is also used to treat the tricuspid valve regurgitation. The surgeon repairs the torn leaflet with a patch to correct the leaking valve and eliminate blood backflow. Now looking at the pulmonary regurgitation. Pulmonary regurgitation is also called a pulmonic regurgitation. It is a leaky pulmonary valve. It helps control the flow of blood. Sorry for the spelling mistake. Flow of blood passing from the right ventricle to the lungs. A leaky pulmonary valve allows blood to flow back into the heart chamber before it gets to the lungs for oxygenation. There are usually no noticeable signs of pulmonary regurgitation. Signs that can be detected during a medical exam include a heart murmur. Eventually, the right ventricle can become enlarged. Rarely, these conditions can progress to heart failure, which can create more noticeable symptoms such as chest pain or discomfort, fatigue, lightheadedness, or fainting. The causes of pulmonary regurgitations, it usually occurs as a result of surgery for repair of the tetralogy of Fallot or carcinoid syndrome, rheumatic fever, and complications after catheterization. The most common cause is pulmonary hypertension. Less common causes are infective endocarditis. Treatment is focused at the underlying cause that created the valve problem, which is obviously their pulmonary hypertension.
Good evening. My name is Nolwazi. I'll be speaking on congenital mitral valve regurgitation. So mitral valve regurgitation is defined as a leakage of blood backwards through the mitral valve each time the ventricle contracts, which is caused by the failure of the heart's mitral valve to close tightly. Congenital mitral valve regurgitation is a rare disease occurring in infancy or childhood. Usually, congenital anomalies of the mitral valve occur in association with other cardiac lesions, and often more than one component of the mitral valve apparatus is involved. And in mitral valve regurgitation of rheumatic origin is rare, but it is the most common valvular involvement in children with rheumatic heart disease. Anatomically, the mitral valve consists of the left atrial wall, annulus, leaflets, chordae tendineae, papillary muscles, and the left ventricular wall. The mitral annulus is an integral part of the fibrous skeleton of the heart. The normal mitral valve has two leaflets, anterior and posterior, that act in conjunction with the subvalvular apparatus as one functional unit. The mitral valve leaflets are separated by the anterior lateral and posterior medial commissures. Beneath the commissures lie two corresponding papillary muscles, which are extensions of the subendocardial ventricular myocardium. Chordae tendineae from the papillary muscles insert on both sides of the corresponding commissure, so each valve leaflet receives chordae from both papillary muscles. Okay. The mitral valve The function of the mitral valve depends on the normal function and integrity of the leaflet annulus, chordae tendineae, papillary muscles, and subjacent left ventricular myocardium. Abnormalities in any of these components, either individually or in combination, produce dysfunction of the mitral valve unit. Okay, the functional classification of mitral valve regurgitation has three types. There's normal motion of the leaflets, prolapse of the leaflets, and restriction in motion of the leaflets. And then on the annulus, there's dilatation, which is secondary due to ventricular dilatation. On the leaflets, there is usually a cleft or leaflet defect, which is a hole due to localized agenesis, mitral valve prolapse, rupture or elongated chordae tendineae, congenital perforation or displacement, as seen in Epstein's anomaly of the mitral valve. The subvalvular apparatus. In the subvalvular apparatus, the bridge of fibrous tissue, which is called an anomalous arcade with shortened or absent chordae. There's shortened chordae tendineae and abnormal papillary muscles. In the pathophysiology of congenital mitral valve disease, malformation of the mitral valve apparatus results in mitral insufficiency, significant flow obstruction or regurgitation of the mitral valve, which results in elevated pulmonary venous pressures and pulmonary congestion. If left untreated, pulmonary vascular occlusions change and pulmonary hypertension leads to right ventricular hypertrophy and right heart failure. In rheumatic disease, mitral valve leaflets are shortened because of the fibrosis resulting in mitral valve regurgitation, with increased severity of mitral regurg, dilatation of the left atria and left ventricle results, and the mitral valve ring may become dilated. Pulmonary hypertension may eventually develop, but this is less common in mitral regurgitation than in mitral stenosis. Okay, with the signs and symptoms, some patients are asymptomatic with mild regurgitation, and some patients present with a history of fatigue and palpitations, dyspnea on exertion, and low extremity edema. On diagnosis, on pulse, there's usually sinus rhythm with mild regurgitation, atrial fibrillation secondary to dilatation. With the heart sounds, there's a soft S1. The S2 may split widely as a result of shortening of the left ventricular ejection and early closure of aortic valve, and a loud S3 is common. With murmurs, there's usually a pansystolic murmur which radiates to the axilla and may be associated with a thrill. The absence of a murmur in mitral regurgitation does not preclude a cleft mitral valve. There is also an apical mid-diastolic murmur, which is a low-pitched mid-diastolic murmur that is present in patients with larger amounts of mitral regurgitation, and this reflects the increased antegrade flow across the mitral valve. And then on this image is a 2D echo, which it's a 2D TOE, which is a peristernal long axis view from a patient with isolated mitral valve cleft. On the left is preoperative, and the image on the right is a post-operative image of the mitral valve. Medical management of mitral regurgitation includes prophylaxis against recurrence of rheumatic fever, which is important, and activity needs not be restricted in mild cases. Afterload reducing agents such as ACE inhibitors are particularly beneficial. Anticongestive therapy is provided if congestive heart failure develops. If atrial fibrillation develops, which is rare in children, propranolol or digoxin is indicated to slow the ventricular rate. Indications for valve surgery are symptomatic patients with severe mitral regurgitation, asymptomatic patients with severe mitral regurgitation, and left diastolic dysfunction with an EF that is less than 60%. Surgery may be considered in patients with preserved left ventricular function if the likelihood of successful repair without residual MR is great. For children, intractable congestive heart failure, progressive cardiomegaly with symptoms, and pulmonary hypertension may be indications for valve surgery, repair of underlying cardiac lesions. With surgical interventions, there is eccentric annuloplasty, ring annuloplasty, leaflet plication and caudal shortening, suture of the cleft if present, and valve replacement. Valve repair surgery is preferred over valve replacement in pediatric patients for central regurgitation with dilated annulus. Annuloplasty is performed by commercioplasty. Valve repair has a lower mortality rate than replacement, and anticoagulation is not necessary. Here is a picture of a mitral valve being repaired and a annuloplasty band being sutured and placed. The next slide is of a mechanical valve and tissue valve, which are used in mitral valve replacement. With post-operative complications, there's usually low cardiac output, bleeding and infection, neurologic complications, arrhythmias, and pulmonary insufficiency. Risk factors include young age, preoperative functional status, associated cardiac anomaly, and with the long-term results, most survivors improve functionally, and they have a better for mitral valve repair than in mitral valve replacement. On follow-up treatment, the valve function of either the repaired natural valve or the replaced valve should be checked by echo and Doppler studies every 6 to 12 months before and after intervention. After replacement with a mechanical valve, warfarin and low-dose aspirin are indicated. This is to achieve an INR of 2.5 to 3.5. After replacement with a bioprosthesis, aspirin alone is indicated at the dose of 80 milligrams per day if there are no risks. When there are risk factors such as atrial fibrillation, previous thromboembolism, left ventricular dysfunction, and hypercoagulable state, warfarin is also indicated. Thank you. Do you guys have any questions?